Hello and welcome. I'm Dr. Ruchi Gupta. We have all heard how food allergies are on the rise. We see it in our clinics, our classrooms, and in our own families. But now we have an opportunity to prevent peanut allergy, an often lifelong and severe food allergy, and pediatric clinicians are essential to making this happen. In the next few videos, we will explain the science behind it all, review the guidelines for peanut allergy prevention, and how pediatric clinicians can implement them, including how to assess risk status, specifically severe eczema. We'll also describe tools that have been developed to support you in doing this effectively in your clinics. Together, we can prevent the development of peanut allergy. Thank you. This is a great time to talk about food allergies. The rise in food allergies are multifactorial and have a lot to do with our current lifestyles, including our dietary practices and living environments. One prominent theory, called the dual allergen exposure hypothesis, proposes that when infants are exposed to food proteins via a broken skin barrier, as occurs in eczema, the body can respond by mounting an inappropriate immune response that leads to allergy. However, if an infant is first exposed to a food through their gut by eating the food, this will lead them to establishing an appropriate immune response and not developing allergy to that food. Investigators tested this theory in a landmark Learning Early About Peanut Allergy study, which is otherwise known as the LEAP study. In this randomized controlled trial, high-risk infants with severe eczema or egg allergy either received peanut products early in life between the ages of 4 and 11 months or did not receive any peanut products. The group that was exposed to peanut products decreased their development of peanut allergy by 80%. The number was so striking that new guidelines were developed in the United States to encourage peanut product introduction. These guidelines are called the Addendum Guidelines for Peanut Allergy Prevention in the United States and were developed by an expert panel at the National Institute of Allergy and Infectious Diseases and supported by the American Academy of Pediatrics. This report includes recommendations for high-risk infants with eczema, as well as low-risk infants without eczema. The guidelines encourage pediatricians to assess infants around the 4-month child care visit. We will now discuss each of the 3 recommendations in detail. Guideline 1 is for high-risk infants who have severe eczema or a history of already developed egg allergy. For these infants, pediatric clinicians should order a specific IgE to peanut and/or refer to an allergist. If the IgE, often called RAST, is greater than 0.35, this is considered positive, and the infant should immediately be referred to an allergist to determine if further testing or an oral food challenge is needed. If this value is negative or less than 0.35, the family should be encouraged to start peanut products at home right away.
Now that we have a good plan of care for treating the eczema, we should talk about food allergies. Your baby's severe eczema puts him at a high risk for developing food allergies. The good news is, there's something we can do to prevent peanut allergy, which is the most common allergy amongst children.
Prevent peanut allergies? How?
Well, it's as simple as just feeding your baby peanut-containing foods early and often. You want your infant's immune system to recognize peanut as a food that's safe. By feeding your baby peanut-containing foods early in life and keeping it in your baby's diet, this can prevent your baby from developing a peanut allergy.
Really? How do I do this?
Since your daughter's eczema is severe, I'd like to order a blood test called a peanut IgE, and if that's high, I'll refer you to an allergy specialist. However, if the tests are negative, you can introduce peanut products now. There are many options for how to do this, including peanut powders, peanut butter thinned out with water, or applesauce. You'll want to do this several times a week, and I'll give you an instruction sheet to explain how.
Does this only work for peanuts or for other foods too?
That's a great question. Currently, we have strong evidence on prevention of peanut allergy. The American Academy of Pediatrics has stated that no foods should be delayed. And in general, research supports introducing lots of different foods in your child's diet, one at a time.
Wow, that's really helpful. I didn't know any of this until today.
Guideline 2 is for infants with mild or moderate eczema. These infants do not need any testing and can be fed peanut-containing foods starting around 6 months.
It sounds like daily bathing and barrier creams are keeping the eczema under control. Now that she's 4 months old, we should also talk about early peanut product introduction. Your baby's eczema is mild, so she can start peanut products in her diet soon after starting other solids. I have a handout that will explain how to do this. Recent research studies show that by doing this, you can actually prevent peanut allergy, which is the most common allergy among children.
Guideline 3 is for infants with no eczema. Although eczema is a major risk factor for food allergy development, some children without eczema can still develop food allergies. For these infants, the NIAID guidelines do not stress a specific time for peanut introduction. However, please remind your families not to delay introducing peanut products. They can start introducing peanut-containing foods starting around 6 months after the introduction of other foods.
How exciting that little Johnny is ready for solids. Do you have any other questions regarding solid foods?
No, I don't have any other questions right now. I think he looks ready to try.
There is one other thing we should discuss. Have you heard about early peanut product introduction?
I actually read something about it online, but what exactly is it?
Recent studies have shown that when infants eat peanut-containing foods like peanut powder, peanut butter, or peanut puffs, they are less likely to develop a peanut allergy.
Oh yes, the article I read mentioned this. What age do we start Johnny?
First, you'll want Johnny to try a few other solid foods. Let him have some practice getting used to using a spoon and showing you that he can swallow well. But once he's done that, you can add thin peanut butter or powder and see how it goes. The key is, you don't want to delay him having peanut in his diet. You can start around 6 months.
Thank you again for your time. Remember, together we can reduce the development of peanut allergy. Now that you know all about early peanut introduction guidelines, how do you incorporate these recommendations into your practice? We know pediatric clinicians have a long list of things to cover for each well child check. A national survey of pediatricians found that many knew about the guidelines, but only 1/3 implemented them, citing practice barriers as a major concern. To address this, a team of researchers developed iREACH, a clinical decision support tool that is built into the electronic medical record. iREACH supports pediatric clinicians in 4 distinct ways. Best Practice Alert, or BPA. There are a few BPAs that will assist pediatric clinicians with early peanut introduction. The first will appear when you open the chart of a 4 or 6 month infant well child check, reminding the clinician that this infant may need counseling on early peanut introduction. The clinician can then decide at this point if they would like to put some pending orders in based on the child's eczema status. If the pediatric provider sends a specific IgE for peanut, BPAs will serve as reminders of necessary next steps. For example, if the specific IgE to peanut is greater than or equal to 0.35, it will recommend the infant is referred to an allergist for further evaluation. Alternatively, if the specific IgE to peanut is negative, it will alert the provider that they can go ahead and counsel the family to start peanut introduction. Orders. iREACH facilitates orders for specific peanut IgE, as well as referrals to allergists. Notes. iREACH templates can make it easy to document conversations and anticipatory guidance provided around early peanut product introduction. Family education. a handout developed by the NIH and modified for literacy by iREACH study team discussing early peanut introduction will be available for you to give to families or be printed with the patient's after-visit summary. These handouts explain how to start peanut product introduction, including how much, how often, and what signs and symptoms to look out for. Now let's walk through how iREACH helps make this process easier.
Now that we have a good plan of care for treating the eczema, we should talk about food allergies.
Wow, that's really helpful information. So we should go see an allergist.
Let's get an IgE test and see what the results are. If that level is high, yes, I'll refer you to an allergist.
Here is the peanut education handout for you to review while we are waiting for your test results.
Each of the iREACH tools are available regardless of the infant's risk level, including the reminder provided when you open the chart, orders for IgE or referrals to see an allergist, easy and efficient documentation of early peanut product anticipatory guidance, and the handout on early peanut product feeding for families. Additionally, at 9 and 12 months, the iREACH tool will prompt you to assess how well peanut product introduction is going and provide a section in the progress notes to document this. We know efficiency is so important for pediatric clinicians, and our research staff will support you to incorporate iREACH's tool into your current workflow. Also, all of the information in this video about the iREACH tools, as well as a detailed step-by-step instructions, will be provided to you in a handout that you can reference as and when you need. Thank you. The importance of categorizing eczema and tools that can help. Eczema, more accurately called atopic dermatitis, AD, is a major risk factor for developing food allergies. The LEAP study focused on infants with AD, and the addendum guidelines rely on pediatric clinicians to identify and categorize infantile AD to help guide families. While many pediatric clinicians feel comfortable diagnosing AD, categorizing it as mild, moderate, and severe might be a bit more challenging. This module will provide a thorough review of AD and a specific clinical scale that can help determine who has severe AD and needs testing prior to peanut introduction versus who can have peanut products introduced at home without testing and referrals. AD is a chronic pruritic inflammatory skin disorder, often with a relapsing and remitting course. The prevalence in American children is between 10 and 13%. Affected children have a 5-fold increased risk of developing a food allergy, and this risk is further increased in those with early onset and severe AD. The diagnosis of AD is based on 3 essential features. Number 1, pruritus. AD has been called the itch that rashes. Number 2, eczema. Dermatitis, inflammatory skin lesions. And number 3, typical morphology and distribution, such as erythema, papules, vesicles, erosions, and lichenification. They can develop post-inflammatory, hypo or hyperpigmentation. Now, the distribution differs based on age, and that can be seen in this image. So in infants from birth to 2 years, you usually see it on the face, the cheeks, the scalp, and the ears. Extensor extremities and seborrheic dermatitis can overlap. Now in childhood, 2 years to puberty, you can continue to see it on the face, cheeks, but it moves into the flexural extremities. And teenagers to adults, it's localized flexural extremities, hands, and even the dorsum of the feet. Other clinical features that support the diagnosis include a rash that flares and remits, the hallmark history in a patient with AD, and a positive family history for allergic disease in either one or both parents. There are some variations in AD of which to be aware. Some children with AD show nummular or coin-shaped lesions with sharply defined oval scaly plaques on the face, trunk, or extremities. Erythema in children with skin of color is much more difficult to see. The typical bright red seen in light-skinned is muted, duskier, sometimes purple-covered, and more difficult to appreciate as pigmentation is darker. Follicular accentuation may be present, and lesions may be more papular, and pigmentary changes, including hypo or hyperpigmentation, as well as ashy or gray-brown discoloration, may be seen. In addition to diagnosing AD in infants and recognizing the increased risk for food allergy, NIAID guidelines require pediatricians to categorize eczema as severe versus mild or moderate. There are very detailed scoring tools like ScoreAD or EASY that can be used to do this. However, it's not practical for these to be used in daily clinical practice because they require both time and extensive training. Simpler atopic dermatitis scoring systems have been used and evaluated. These include the 3-item severity score and the Validated Investigator Global Assessment for Atopic Dermatitis, the VIGA-AD. The VIGA-AD was developed by Eli Lilly and Company and evaluated by dermatology experts. The clinical scoring tool is divided into 5 categories, ranging from 0, clear, to 4, severe. 0, clear is really no inflammatory signs of atopic derm. 1, almost clear, barely perceptible erythema, barely perceptible induration papulation, and or minimal lichenification with no oozing or crusting. 2, which is mild, is slight but definite erythema, which is pink usually. Also induration and papulation, slight, and or slight but definite lichenification. Again, no oozing or crusting. And then 3 gets into moderate, which is clearly perceptible erythema, dull red, clearly perceptible lichenification and papulation, and or clearly perceptible lichenification. Oozing and crusting may be present in 3s. 4, which is severe, is marked erythema. The color is usually deep or bright red, marked induration, papulation, and marked lichenification. The disease is widespread in extent. Oozing and crusting may be present. In this education module, we will focus on how pediatric clinicians can apply the VIGA-AD when doing infant exams in order to determine mild, moderate, and severe eczema. In doing so, pediatric clinicians can then implement the NIAID peanut prevention guidelines. So first, we have mild. In these images, the erythema, papulation, and lichenification is definitely there, but it's slight. If you were able to touch the lesions, you would note mild induration as well. There is no oozing or crusting. This is mild atopic derm. Moderate. In these images, the erythema is clearly present, as are the papulation and lichenification. During the examination, you would also appreciate induration. Children with moderate AD may also have oozing and crusting, which can be seen in these images. Severe eczema. AD is often bright red or deep purple, depending on the skin color. and there is marked papulation, lichenification, oozing, and crusting. On examination, marked induration would also be noted. The lesions are widespread. Since determining severe AD is critical for adhering to the NIAID guidelines, here are some additional tips. If oozing crusting is present, then the AD is either moderate or severe. Keep in mind that oozing and crusting can also be caused by infection, so that can be a confounder. If unsure between moderate and severe disease, use extent to determine the severity. If the lesions are widespread, then it would be appropriate to diagnose severe atopic dermatitis. Also consider if darker skin is modifying the visibility of the erythema. Marked erythema can appear as dusky or deep purple. Also, other factors in the clinical history can help you determine if the eczema is severe. For example, the NIAID states, severe eczema requires frequent use of prescription steroids, calcineurin inhibitors, or other anti-inflammatory agents, despite appropriate use of emollients. We know that this is a lot of information. In order to support busy practitioners, we have included the vIGA-AD and example images on a scorecard, which is available to you in your clinics and via your EMR. Thank you for watching. We hope this video and the AD tools described will support your ability to apply the NIAID peanut prevention guidelines.